This is an educational video from Precision Analytical. This one's going to be a little bit of a casual review of BHRT scenario, just from a recent conversation with a patient that really ties in strongly to some of the education that we put out, but in a real practical way. So when we're looking at hormones, you're looking at estrogen and progesterone throughout the life of a woman. It starts off low, of course, and then you get these reproductive years where you're making more hormone, and then of course you hit menopause, and then with a lot of people you're going to put them on HRT, and to some degree you're going to return some of that hormone. And the simple thing we want to start with is that there's not simple equivalency between measuring an estradiol or a progesterone in a young healthy woman and when there is exogenous hormone applied, because it really depends how you apply the hormone. So we've spent a lot of time putting together this testing matrix that you can get on our website. The whole thing is hyperlinked to videos to show you, for example, if you're on oral progesterone, what does serum and saliva and 24-hour urine have to offer? And for some of these situations, our Dutch model offers some information that we think is improved in some of these scenarios. But when you're looking at these, the black ones are things that really are not recommended. If it's gray, then there are some caveats, and if it's green, then it should work just fine. So as we look at in this particular situation, we're going to look at oral progesterone and then some other situations. But what we say about oral progesterone is when you're looking at, in this case, we're going to look at some saliva results and some problems that were created potentially because of the interpretation, is actual progesterone values, and we'll show this, do not increase to premenopausal levels, but they return to baseline quickly. Metabolites can cause falsely elevated values. The lab values may increase, but they're not really clinically meaningful. So let me show you the actual data from 3 results from one patient. So in one test, the first one, she's on a milligram and a half of oral bias, and she would later switch to topical, and she's taken some oral progesterone. Test number 2, again, she switched to the topical bias, and then her oral progesterone's down a little bit. There was actually a test here in between, but we're just looking at these 3. So test number 3 here, again, staying on the milligram of topical bias and then taking even more oral progesterone. So we've got estradiol results, progesterone results, the ratio, and then some estriol results over those 3 time points, and then we can look at the ranges as well. So oral progesterone, and as we get into this topical bias. So there are a lot of different issues you could focus on here because it's pretty complex. But let's just look at the progesterone. What's wrong with using progesterone results in this scenario? So when she's on 200 milligrams of oral progesterone at bedtime, her salivary progesterone is 76. She cuts down her dose, and the number goes down a little bit, so that kind of makes some sense. And then she turns her dose way up, and her results are the same. But when you look at progesterone in saliva, the ranges that are given for oral progesterone is 100 to 300. So these all 3 would be considered low given this scenario with the reference ranges given. So does that make sense? Should you look at this and say my oral range is 100 to 300, I did not hit that number in any one of these situations, and so I'm going to increase my dose. More than 340 milligrams of progesterone, does that make sense? So here's what happens when you take oral progesterone. These are serum results. Okay, so in serum, the true value of oral progesterone with 100 milligrams, the luteal range, so a premenopausal woman is going to be up in here, about 6 to 20, something like that. With 100 milligrams, the blood levels don't get anywhere close to that, and they come back down really quickly. Okay, so LCMS is going to be your true value. However, the lab results, the type of testing that's used that would be similar to the type of test used here in saliva, what happens at that same time point is the lab value actually hits 12. It actually hits a luteal level. Now, why is that? The difference between these 2 values is caused by the metabolites of progesterone falsely increasing the value from the immunoassay. Okay, the other thing we can notice here is if you take this at bedtime and you test in the morning 8 or 10 hours later, those values have come down, right? The true value hits baseline at 2 hours. So anything you get out in here that's above baseline, it's not even progesterone, right? Even if this is sustained release, it's not progesterone. You're just getting some of the metabolites pushing those lab values up. Okay, so what are some of those metabolites? Well, look at allopregnanolone. So allopregnanolone, after oral administration, the levels get huge, super physiological. You get a lot of metabolites when you take it orally because of the extensive gut metabolism, and this is why women sleep well when they take oral progesterone, because these alpha metabolites are helpful for sleeping. Now, what we do in our urine assay is we're measuring metabolites. So it actually fits pretty well in this situation to say, okay, let's look at these two women. The beta pathway and the alpha pathway is represented here. Okay, the alpha pathway is where allopregnanolone, this compound, lives, down that alpha pathway. So if you look at these two women, they're pushing down this more inert pathway roughly the same, but the allo, the more active metabolites, are far more represented in this case here. So I don't want to get into this too much because that's not overly the point here, but this is what we would do to evaluate, is we would see, okay, well, which kind of metabolites are we making here? Because if you're making not enough of the alpha metabolites, maybe you could justify a little bit more. If you're making gobs of the alpha metabolites and you're still not sleeping well, probably it makes sense to go looking at some other issues, cortisol, melatonin, what have you. Okay, so in this case, the progesterone results as measured in the morning are not, if they were accurate results, they're not really supposed to be elevated because it's supposed to be gone. So this approach of using an elevated range above a postmenopausal baseline and then pushing levels up into that is at best arbitrary in terms of lining up a dosage with a particular result. It just doesn't work. So let's continue on in this example. So that the progesterone results are highly problematic when you're taking them orally if you want to use serum or saliva. It's just not a good match. Let's look at the E3 results. It just so happens in this case, and this is going to be pretty rare, but it's really interesting. So I'm going to walk you through this. Okay, she tests on topical bias here, and look at her results. And then she tests on topical bias here, and look at her results. What do you notice? The estriol went absolutely crazy, right? It went from 25, which is about what you'd expect on transdermal bias. So if you look at the estriol ranges, they're saying, hey, if you're on bias therapy or topical estriol, 5 to 100. So that 25 result makes some sense. But 1300, what's that all about? So come to find out, the patient is using an estriol facial cream. So she's using an extra dose of transdermal estriol. Now, had she put it on her foot or her thigh or her abdomen, the salivary results would have probably gone up a little bit. But if you put it on your face, it's going to go up a lot, because this very, very small study, but very interesting, shows us that when a gentleman is putting testosterone up around the clavicle and the forearm and further away, what you get is this. I mean, look at these numbers. They're absolutely huge. It's an exponential logarithmic curve here. So you get way more hormone in that saliva gland the closer that you put it. So is that an indication of what's going on in all of your tissue? Of course not. It's diffusing into the saliva gland from the facial cream. Possibly it's contaminated, but it's very likely that it's just the level you get when you put estriol on your face. So now, is that estriol value of any worth? No, of course not. Okay, this 1300 does not mean that you're, if the range is 5 to 100, you wouldn't say, hey, I have 10 times too much estriol. It just doesn't work well. That's not a good monitoring situation. Okay, but look what else we notice. The estradiol has gone from 2.6, which is within this optimal range that's given, up to 11.2. Now, why would that be? Because this is actually an interesting case. So one could theorize that the topical bias, the effective dose of that bias is actually increased from test 2 to test 3, even though the supplementation has not changed. That seems odd. Well, let's look at this a little closer, and this gets a little bit nerdy in a chemistry way in terms of the analytical part of this, but when you look at a salivary estradiol test, a test that a lab would use, when it sees estradiol, the lab value goes up 1-for-1, right? 100% cross reaction. If you add a whole bunch of estrone, the value will artificially increase by 0.2%. That's reasonable. That's not going to cause a problem. And estriol will increase it by 0.05%. Now that's also very reasonable. So if you have normal levels of estriol, it's not going to affect the assay. However, in this case, because the estriol is so high, right, 0.5% is around 6 or 7. So 0.5% of this, which is, let's say, 7, gets added to this to make this, if that makes sense. So basically, the estriol is in such excess, and the way that salivary assays work, it's going to increase that value artificially. So that difference from 2.6 to 11.2 is completely artificial. Now, you might be able to piece it together in this situation because you tested estriol, right? But what if you didn't test estriol? You just get an 11.2. Your patient happens to be using an estriol facial cream. If you didn't know it, that's a type of situation where you can get yourself into some trouble because of the cross-reactivity potential with immunoassays. So is that usually a problem? Not usually, but it's something to keep in mind. If you use really high levels of one hormone, it can affect the other. That is one advantage of a urine assay, is you don't use immunoassays. You use mass spectrometry. And in mass spectrometry, you can put an infinite amount of estriol, and it will never affect the estradiol, which is a nice thing. So what's wrong with the estradiol in this case? It's falsely elevated because of the estriol. Now, let's talk about this, because this is something that really, I think, is overused in terms of interpretation. What about the progesterone estradiol ratio? Now, when you're in an endogenous situation, this ratio is somewhat interesting. I think it's still overused a little bit, but it's somewhat interesting. But in cases like this, let's look at this. The ratio, which we're saying should be optimal, is 100 to 500, when estradiol is 1.3 to 3.3. Okay, so in this case, the estradiol in this case, and in this case, they fit that criteria, right? It's between 1.3 to 3.3, yet the ratio is not even close to 100, right? And in this last case, because of this cross-reactivity issue, it's 3. It's super low. So if you're going to look at that and interpret it for what it appears to be, you're going to say, oh my goodness, I have this horrible imbalance of estrogen relative to progesterone, when in fact, oral progesterone has been shown to counteract the effects of estrogen in terms of protecting the endometrium and that sort of thing. The problem is the lab test in this particular scenario is not geared up to reflect that well, so you have to be careful in terms of the interpretation. Should you give, she's taking 340 milligrams of oral progesterone, and yet her ratio is terrible, right? Even if the estradiol was accurate, the ratio would still be way low. So should you continue to give progesterone in a case like that? Of course not. Right? We've got to stop and interpret this a little bit better than just to follow these ranges and numbers. Okay, so it's a little bit tricky. So again, it brings me back to the conclusion, and this is why we put out this educational information, is to know there's nothing wrong with salivary progesterone measurements. We just did a study that showed that for most of the labs that have good methods, they correlate well to serum. Now, the estradiol is not going to correlate as well, and that's a side issue, but the progesterone correlates fine. And if you're, in a particular situation, it can monitor them quite well. But with oral progesterone, it doesn't work. And so with Dutch, we've got these active and inactive metabolites, and it's an effective way to get some useful information on monitoring the therapy. And when you get to the transdermal hormones, that's a whole nother conversation in terms of what those numbers really mean. And I encourage you to watch our video on transdermal hormones if you want to see some more information on that, because it's a pretty complex topic. But this is a particular example where I think you may have been in a better position if you used a test that's better geared towards this. So let me show you what a result might look like. Here's a patient who's on similar dosing, right? So here's the estradiol, the estriol, and the estrone. Now, this particular provider happens to get a better response in urine than most when they take transdermal hormones, so the estradiol is actually really strong. So the postmenopausal range for these is that little purple band, and then between the stars here is the premenopausal range. So these are really significant increases from 1.5 milligrams of bias. So that's a lot of hormone. But what we have to know, and again, you should watch the transdermal hormone video if you want more information, but the salivary results are going to be really, really high when you're taking them transdermally. So we think of urine as, to some degree, an underestimation of what some tissue may be experiencing when the route of administration is transdermal. Okay, so you want to be a little bit careful as you're dosing with urine values if it doesn't go up quite as much as you think. But the extra information you can get is you can look at this phase 1 metabolism and see, we want to see about 70% 2-hydroxylation compared to these other metabolites. And in this case, we'd see it. It's 76%. So that's good. So there's a lot of estrogen going down this more protective pathway. So that's what we want to see. Now, in this particular case, she was taking transdermal progesterone, and the results are up above baseline. So there's your postmenopausal kind of baseline range, and she's just into the premenopausal range. So you can use that to evaluate it. But again, we think of this as an underestimation to some degree, especially with progesterone, that results in enormous elevations in salivary samples, in capillary blood spot samples, and the urine and the serum tend to lag behind a little bit. Now, in the situation we were just talking about with oral progesterone, if she was on oral progesterone, then we would be able to evaluate, as we mentioned, the alpha metabolites and the beta metabolites and see, if maybe there's a justification for adjusting the doses when you take the clinical picture into consideration as well. Now, this would be in contrast to somebody who looks like this. This person's on a very similar dose of transdermal biased. But in this case, the estradiol is a little bit lower. The estrone's actually a little bit below the premenopausal range, and the estriol is a little bit higher. What you'll see with this one, though, is that the metabolism is definitely worth paying attention to. The 16-hydroxyestrogens are on the high side, and the 2-hydroxyestrogens are very low. So in terms of, and then we could also evaluate methylation with this, which I didn't show here, but you're supposed to get about 70% 2-hydroxylation. She's at 20. So hardly any of the estrogen is going down this pathway. It's going down the less favorable pathways. So that's something that you can address. So that information is always available with the urine testing, even if there are some challenges with the transdermal hormones in terms of tying the dosing in as strongly as we'd like with the absolute values. And then again, we can look at the progesterone. So when you're looking at HRT, please do feel free to use the resources that we have. Again, working through which testing modality you're using, which scenario you're up against, and then trying to figure out where there's a good match. And in some situations, sublingual is a good example of that, of where you really have to rely on the clinical picture a little bit more for dosing, because the testing is very challenging with any of the tests when you're looking at sublingual hormones. So I hope that's been helpful. We really are here to help you make good decisions when it comes to hormone testing with various situations. And if you have any questions or feedback, feel free to email or call with any feedback you might have, and we look forward to continuing to work with you.